what is the indication for tennis elbow surgery? There is, you can see, chronic lateral elbow pain for more than 6 to 12 months, failed conservative management even after the physiotherapy, injections and NSAID, and functional limitations affecting daily motions. And at the last, if there is tendinosis of the ECRB tendon on the MRI imaging. So before going for tennis elbow surgery, you should know about the anatomy of the elbow. You can see this, like there are common extensor origin of extensor carpi radialis longus, ECRB, and radial head. In this, most two important structure is radial collateral ligament and ulnar collateral ligament. So during the surgery, we have to avoid the damage of ulnar collateral ligament to avoid the instability. So now I'm going to take you through the steps of the surgery. Do the release of extensor carpi radialis brevis muscles for the resistance cases of tennis elbow. Here I mark the lateral epicondyle. I can feel it here, and from here all the muscles of extensor compartment is going to originate, and this is for the extensor carpi radialis longus. And most important thing is we have to identify the extensor carpi radialis brevis. We have to palpate the radial head, which I have marked, at like 0.5 centimeter in thickness, and just towards the radial head, this is the extensor carpi radialis muscles, and on the back side there is a lateral collateral ligament. So this is the most important thing. We have to stay anterior and down, don't go back, otherwise it will lead to the instability of the shoulder joint. So let me give the incision directly over the epicondyle. This case I'm doing under tourniquet, so I'm not expecting too much bleeding. Pick up now. So after a skin incision, we have to release this fat pad. So, and after this we'll go check the fascia. Give me the self-retaining, please. Self-retaining. So you can see this here. This is the, I think we gave before the depomedrol injections he took from outside, and this is the particle of the depomedrol, which you can see clearly. So this is the resistance case. This is the depomedrol which we are going to wash. So you can see that how the steroid is working. So that's why you have to avoid the steroids in this kind of cases. Knife, deep knife.
Yeah.
Always try to palpate and then release the fascia. Fascia here, you can see this. I have to just release from the front. So see the side effect of this depomedrol. The muscle is torn here. So let me expose the lateral epicondyle and then I come back. So this is the lateral epicondyle, and you can see this area is a bit inflamed, and this is the ECRB tendon. So just knife, please. I'm just going to release this epicondyle. Always try to stay anterior, safer for you. So posterior split. So let me make the flap and then I'll come back to you. We have released the flap. You can see this is the anterior common extensor group and this is the posterior part, and this area of the tendon we cannot differentiate actually, but according to the anatomy we have to see that this is the part of the ECRB tendon which I am going to release. So cautery please, and then after that we'll decorticate the epicondyle. Always try to release the inflamed portion. Give me the retractor please, the retractor I need. So you can see this wear and tear because of the deployment, so better to release this, otherwise it will cause the patients again pain. So now I have removed the part of the extensor tendon of the ECRB, and now we are going to do the decortication of the epicondyle. So now we have released this ECRB tendon from here, and now this is the part of the lateral epicondyle. We are going to just debride it. Just 3 to 4 millimeter. You can see there is no bleeding here. So once it is, sister can hold it. So yes, okay. So now I have removed this. You can do the front part of the So you can see this now, the bleeding has just started from the cortex. So this we have done now. Little bit anterior we can do. Perfect. So now I did the decortication, and you can see the bleeding is also there. So now we are going to close this. We'll close in the fascia. It's okay. Done. So this way. So now you can see this. There is a release of the ECRB here. And after now just put the closure of the fascia, and after that the skin. So we have decorticated the bone here. I'm not able to feel the lateral epicondyle now, and this is the ECRB which I have released. This is the remnant of the ECRB. Now we are going to close this fascia. Can you release this please? Take a 90-degree. Yes. Good. So just close the fascia with some sutures. So now we have closed the fascia. One more stitch I think I have to put here. Kind of relax this place a little bit, yes. So after this I'll put some stitches in the skin. So now we have closed the fascia. Now we are going to close the skin with some cosmetic suture. So this is the final stitch which we have put now. Cut please. Cut here, from small, yes, good. Perfect. And you can see this. And now we will do the dressing and start immobilizing immediately.